What do we see as the clinical implications of LDN's impact on the opioid growth factor receptor axis, particularly in cancer therapy? So should we just briefly touch on that?
Again, I give a lot of credit to Dr. Ian Zagon. I work a lot in the space of thyroid. I have a lot of thyroid cancer patients who I manage their thyroid medication and follow up after. This is also a big plug because what I don't see endocrinologists doing is getting, number one, thyroglobulin tests on their patients. I mean, I do it yearly, but 6 months in the first 5 years, Q6 months. So thyroglobulin is produced by a thyroid gland. If you don't have a thyroid gland anymore, you shouldn't be making thyroglobulin. That's not the antibody. I'm talking about the actual protein. And number two, getting an ultrasound on the thyroid bed in the first 5 years. Doctors don't do that. That's really important. Okay, off soapbox. But Ian Zagon did really great work showing that opioid-derived growth factor and the receptors are involved in different tissues, including the thyroid gland, talking about that with regard to thyroid cancers. And we know this just based on his work and other people's work that more and more we're seeing just that this axis we know is so integral for growth factors that clearly are being implicated for either derangement or use of in tumorigenesis, and how if we can modulate that, right, we can, in number one, help with patients who do have cancer and also to prevent recurrence. So I think it's, again, one of those not ready for prime time, but we know that, as Sebastian is talking about, how these receptors are and these pathways are being reclassified, you know, to be more encompassing and have not only direct effects, but downstream effects that we don't even know about, and how things are synergistic and working together. All we know right now is that it's an incredibly important pathway.
We're just adding to making the medication more bioavailable. If it needs to have serum levels checked when LDN's added, that should be checked again. Ulrich Lanius has a case where Coumadin had to be cut significantly after LDN was initiated. It was more complicated than just adding LDN. Dissociation was a piece of it, but I won't go into detail on that. But
yeah, and I think we're kind of like, there's a number of topics that we're starting to get into, but we also see this with thyroid medications. Usually we can see this decrease of anywhere from 25 to 35% of the dose within the first 3 months, and then following the APO antibodies. APO? No. TPO. Sorry, my brain is like, I'm thinking about all of these different things. Yeah, TPO antibodies. And I actually have a very unique case where the patient, they saw their TPO antibodies increasing because they had increased the dose because the Naltrexone had gone from 4.5 to 6, and the patient was like, oh, do I need more? And the doctor was like, you need more. Once we went back down to about 3 milligrams, we saw this pretty rapid reversal of TSH, and then the TPO antibodies literally went like that about 3 months later. And so they're still trending down, and their TSH is, I think, 0.9. And their TPO antibodies are still falling, and they're almost 6 months into treatment. So there's that. With respect to the OGF receptor, we just see the cancers stop growing. It's still present. The mass is still present. They still have cancer, but it does just stop. And it's really interesting because that growth just slows to a crawl. And that's what we're looking at, is the balancing act of finding the appropriate dose and not too much. Because we can see that dose, when they get it wrong, it starts growing again. And so that is the important piece to that discussion. So imaging is going to be important, and then follow-up. And then after surgical, we would keep them on the same dose, because we're still looking at that sort of, that some of the cells may be present. And we will improve that NK cell activity, and then we will see it get picked up. But yeah, there's a lot going on there. I think we're answering your question, or we're just talking about other stuff now.
I think it's fun.
Just pass the mic. Like, no. No, I mean, I was just going to, if I wanted to throw a very confusing and interesting wrench into everyone's existence, is to read a book called Cancer is a Fungus. And I could actually see the correlation between Candida albicans presence and the way a tumor grows, and the synergy between modulating the immune system with something like LDN would actually have a direct effect on our body's ability to stay on top of that infection. And a lot of patients that we were seeing, there was such a correlation between fungal infection and cancer diagnosis. It's just, and I'm just throwing it out there, but there was a researcher named Doug Kaufman who was literally cutting tumors open and finding Candida albicans in the center of it, and was seeing that their respiratory system and the way that they function in order to maintain their kind of hold in our system is by cutting off our immune system's ability to take care of them. So if you're directing or modulating something like with LDN, if you add something like KPV, if you do other things around it, you could potentially mitigate that growth from being stimulated and just add to not just modulating dose based on growth, but you could actually start to reverse, because there's a whole other conversation where like touching it, but there's so many things in our universe that are anti-cancer and anti-tumor growth, which we could have a whole other panel on, but I'll just keep it at that.
Real quick, microbiologist hat. So Candida is super, super interesting, and patients are now coming to me from across the country who've had things like Candida glabrata, which is multi-drug resistant, and there are some patients with galactomannan deficiencies where they are overgrowing. But most of the time, again, this is not an inherent infection. We all have yeast we all have Candida albicans in us. That's normal. We're talking about overgrowth and genetic and epigenetic factors and our diets that just make this explode. The craziest part is how, when I look at microbiome analysis and I look at Firmicutes to Bacteroidetes ratios, those patients are going to be obese. Their microbiomes are making them fat. So these women, I'm able to say, look, it's not your fault. You are going to have these cravings, and then they get yeast overgrowth, and it fundamentally changes their pathways, including their reward pathways. Obviously, like, it is harder to give up smoking for these people or other drugs rather than sugar. It absolutely is. They are absolutely sugar addicted. So also for the other, that begs like chicken or egg with the whole fungus question when we put patients on like Thomas Seyfried's work, therapeutic ketogenic diets, or Nisha Winters or other people, as cancer is a metabolic process. We're talking about Warburg effect, all of that. And how we're going to also be changing our microbiomes, and we're going to be starving yeast that way. I mean, it's all, it's all part of it. It's super, super interesting. And one other fact about yeast, there was a really cool in vitro study looking at an animal model for Crohn's disease, and it was basically I call it an unholy trinity between E. coli, Candida albicans, and Serratia marcescens. And Serratia marcescens is technically what we call a MySpace organism. It's got extended spectrum beta-lactamases. Yes, that whole unholy trinity between them, they could create this model of Crohn's, right? But even if a patient has overgrowths of all three, which we all have a ton of E. coli, that's our main colonic bacteria, they don't get Crohn's. Who gets Crohn's, right? There are genetics and epigenetics and all of that. And that's where we can look at it and say, okay, if it's a three-legged stool, can I reduce their yeast? Can I give them biofilm busters? Can I modulate them? Can I get them out of that stress state? Can I, help them? Another really fascinating thing, I have a patient who I could not stop bleeding. She was treatment resistant with her IBD. She came to me and she said, my sister also has PSC, which is a known relationship with inflammatory bowel disease and primary sclerosing cholangitis. It's a terrible disease, a fatal one. And she said, my sister's been treated with vancomycin and she's going into remission. Well, I didn't know if I had a leg to stand on to give it to her, so I pulled up her microbiome panel and I did see that she legit had some Clostridial overgrowth. So I was able to put her on oral vancomycin, lupin-specific generic from the regular pharmacy. She's in remission now, because I was able to find something that worked, because she said, lo and behold, this worked for my sister, and she was bleeding for 9 years, and that's why I love microbiome medicine, which is in its infancy, and then you combine it with all of these other, tools. We are more microbial than human, so, it's just fascinating, but it's in its infancy.